and Barbara is going to come up now, Dr.
Yes.
Smith.
Yes.
Oh, you want her now? Okay. All right. Is Dr. Barbara Pullen Smith, are you ready to come on? I'll introduce you.
Yes, I am. Thank you.
Okay. Good.
Okay.
I can't get
Thank
my
you for
video
being here.
on. Okay, sure.
And thank you for sharing the fact about your new book. I'm going to announce it, The New Woman in the Mirror. And I know that the journey that you've taken both professionally and personally resonates with the people here and also with the public. And thank you for being here to share. We've put up your extensive resume, so I don't need to go through all that. But thank you for joining us. You do have a full 20 minutes, and so we'll take it from there. But thank you for being here today.
Well, thank you so much, Dr. Hancock, for the introduction, the kind introduction. And I did need to share my screen, Mary, just a one slide. So do I have permission to share it?
Yeah, sure.
Okay. It's saying it's still disabled.
Can you mute in the background though?
It's not my background.
Uh,
It's, yeah, somebody else has a
Somebody's.
live
Now,
mic.
if you're not speaking, please be on hold so that we mute so that we get a clear. Okay, are you able to share?
No, it says host disabled participant screen
No,
sharing.
I am now sharing.
Okay.
Are you able?
Okay.
Yeah, you're good?
Let's see. We'll
Yes.
see.
I just enabled it there.
Okay, thank you. Nope, it's still saying it's disabled. Let's see
It is not.
here.
It's not coming up yet, Mary.
Yeah,
Yeah.
it's not because I just disabled from my side. I mean,
Mhm.
do you see it now? Because I can see her.
Mhm. Stop. Do you want to?
Miss Barbara, I believe you can do it. You can share.
Okay.
I got
yeah.
it. I got it.
Okay, good. You're on now?
I got it.
Okay, good.
Can you all see that?
Let me see. Me, I can see it.
It says you're starting.
Yeah.
There you go. Okay.
Okay.
Is that it?
Yeah.
Yes, it's just the one slide. Okay.
It's
Okay.
just one. Yeah.
Awesome. Thank you so much. And again, sorry about that little technical challenge
That's
right
okay.
there. But definitely, I'm just excited to be a part of this discussion. And thank you, Mr. Udofia, for inviting me, and Mary for your support and guidance. And I really do appreciate all the panelists who've spoken this morning and for sharing your insights. So it went away again, Mary.
Went away?
Yeah.
Right.
Okay.
Rogers, could you act from your side then?
All right.
Some
Try
reason
again. There we go.
Okay.
All right.
Okay, back. Is it
Perfect. So hopefully that'll stay.
okay,
And
good.
so,
Okay, there it is. All right.
perfect. Yes, we did it. As I was saying, I'm certainly grateful to be joining this important conversation. And my disclaimer is simply, I don't purport to have all the answers, but I certainly am speaking from the lens that I have of 35 plus years of public health experience. And I do want to share just some of the challenges, but some of the public health strategies that have been proven. So, certainly right now, there is this public outcry around the world, against all of the racial injustice and also a public, and rightfully so. I mean, it's just unconscionable what we're dealing with right now. And the world is also crying out against the disparities around COVID-19 in terms of Blacks contracting and dying at higher rates from the pandemic, from the virus. And so I've been just really asking myself, what is it? What's the collective ask? What is it that we need to do? What is it that we need from outside of the Black community, but also what is it that we need from inside the Black community? And so I needed a way to kind of frame my remarks. And so I thought this slide, and I want to take time and kind of go through each of the constructs in this slide, because it helps me to sort through the rhetoric. It helps me to sort through the noise. There's a lot of people talking. There's a lot of stuff that's being said. but how do we get to the get to? Because that's all I'm about, getting to the get to. So what are we even asking for? Are we really talking about equality? We talking about equity? Are we talking about justice? So the constructs are very complex. So let me just kind of talk you through each one and then kind of come out of that with some public health strategies that have been proven that can be replicated wherever we are. The reality, this pictorial really demonstrates the disparities. And those disparities are significant differences between population groups, right? And those differences are unfair, those differences are unjust, and that many of the factors that created these realities we're dealing with can be addressed through systemic change. But you also have to factor in so many of the social determinants and those things that people talk about. Well, poor people, being poor is one of the greatest predictors of poor health. Absolutely. One of the social determinants: unequal access to healthcare, lack of education, the stigma, and of course, the ugly roots of racism. Now, all that's going on in the world has certainly uncovered and exposed racism. But this thing is so deeply embedded within systems. So it's uncovered. But how do we dig it up? How do we get to the bottom line of all of this? So again, reality. These are the disparities that exist now. How do we get past it? So when we talk about equality, equality is pretty much, if you look at the structures, it's giving people equal amounts or the same amount of resources. But unfortunately, the fence, the systemic barrier, is still there. It just makes the system feel good because, we say, oh, well, we're treating everybody fairly. We're giving everybody the same thing. Well, not really. An example in point is just look at the current approach to making COVID-19 testing available. So if the COVID-19 tests were available at all the medical facilities, then certainly the system says, oh yeah, well, we're making it's free of charge. All people have to do is get there. Well, there you go. There are some of the barriers. What if people can't get there? What if people don't even know about where the resources are to even help them? So what about past history? What about the lack of trust of those medical facilities that people are not even going to go in? So if you've not addressed that, then yeah, the system feels good in saying, well, we've made it free to everybody. But that doesn't mean everybody gets to get it. So how do we break down that? So we look at health equity, on the other hand. That's when we start to really look at some of the structures and the barriers that really get to the some of the social determinants of health, that looks at the lack of equal opportunity for health. And I'm saying health because my training and background is public health, but it doesn't matter what you plug in. This discussion is the same. Whether you're talking about economic health, whether you're talking about education, health, whether you're talking about physical health, whether you're talking about mental health, it is the same discussion. So I look at health equity, really is, to me, is when we see health equity, we see equity happening at the point when systems start owning up to their part in helping to create the disparities in the first place. Simple as that. The system itself owns up to contributing to some of the problems. So health equity is achieved when every person gets what they need to attain their full potential. And again, across the board, whether you're talking about education, mental health services, physical health services, economics, it's the same. So what do we do to create equity? And equity means that that somehow the factors that kept people down in the current reality slide, in the reality section, that those things have now been accounted for, have been addressed. And that is some of the social positioning and, some of the social positions people find themselves in, some of those social determinants, like being poor. One of the things that's really clear as we talk about achieving equity is that it's going to require policy changes. It's got to go to the deep root of the deep root in terms of systems and requiring policy changes. So equity strategies give support needed to reach above the system. But if you look at, even in this illustration, even in equity, the barriers are still there. The systemic barriers are still there. So then we say we want justice. Absolutely. And I see justice as the dream. Removing the fences, removing the barriers so that everybody, there are no barriers, so that the systems now are just for everyone. So that's why I use this illustration of equity and how we get there, because it helps, as I said, it helps me to kind of think through, okay, so what? So we know this. So now that we know what we're asking for, and so that helps us to respond to the things that we see and hear. And I'll speak about that in a little bit, I think, in a different way, because we are able, with this framing, and if we frame our thinking like this, we're able to cut through some of the rhetoric and cut through some of the noise. So COVID-19 disparities just, it seemed to shock so many people, so many leaders. And what it did was it just ripped off. It ripped off the Band-Aids. It ripped off all of the, I guess, the very shallow covering for the world to see what people who've worked in this field, who've worked in public health, who are in the healthcare system, who see this day in and day out. But now the world sees that there's this ugly and oozing and festering sore that's there and it's been there. So it's COVID-19 has uncovered, for example, the disproportionate burden of chronic diseases and conditions that have caused Blacks to contract and die from the virus at higher rates. I mean, whether you're talking about, heart disease, diabetes, the things that people have to take medications for, those things that have compromised our immune systems, those things that have been going on for, unfortunately, generations and generations. So that's uncovered the disproportionate burden. It's also uncovered that the social determinants that I've talked about, lack of access to healthcare, lack of resources, lack of education, health illiteracy, public health services, all of these things, lack of access to the basic preventative care that people need, all of these things that of course are impacted by poverty. COVID-19 disparities have also revealed something that's very troubling to me, and that is the inconsistency in collecting and reporting COVID data by race. Now, if we don't know who's impacted at the higher rates, how do we know where to target the resources? And I think, like I can say, in America, I think that's what we were witnessing. In the beginning, it was just reporting just by cases. And then once we started looking more carefully and asked the right questions, is there a difference? That's when the shock of it for some people that, COVID-19 data revealed that Blacks were experiencing these, not only the contracting the virus, but dying at higher rates from the virus. And then the resource, so now I'm still questioning, are the resources keeping up with it, with that data? COVID-19 also uncovered the necessity for more contact tracing. Again, more contact tracing in our communities so that there is some systematic way to identify and monitor those who are at risk or are at risk of spreading COVID-19 so that, they can be tested and go through the public health protocols, of course, to contain the virus. So we haven't been able to cut it off. And so now we are still in the midst of that in terms of seeing the disproportionate impact in the Black community, but we're also lagging behind in terms of the testing and the tracing. And so it also uncovered the lack of access to needed testing for COVID-19 in the Black communities. It uncovered inadequate communication of the risks to Black folks. Now, that one is the one that still is so disturbing to me. Just the risk communications and how things have not happened. So we can't let any of these issues that I've listed go back under the cover. And I think that's why this conversation today is really important, but it's got to be a collective ask. And, I heard some of the speakers from earlier just talk about investing in the infrastructure. Yes, it's the infrastructure for the existing public health system, but it's also the infrastructure for what the new public health system needs to look like. So moving forward, what would we say are just our collective vision beyond the virus? So how do we prepare Black people to speak with one voice, no matter where we are? And this is so that we are prepared for the next thing. There's always going to be a next thing that's going to hit our communities. It just is. We have to look at both what we need to do within the Black community, but also what do we need to ask for outside of the Black community? Because we're talking about strategies to build citizen-centered leadership. We're talking about how do we create equitable communities and what are some of the socioeconomic plans or models that we can put in place. I've honestly been trying to think about how do we, for real, become integral partners in the public health response moving forward. And of course, the public health response and the approach being used is identification, isolation, contact tracing. And part of that has to do with building infrastructure in our communities. So one issue is just around risk communications going forward. So people throw around the term community engagement all the time, but knowing, it is labor intensive and it takes time to build an engaged community, to build the trust in communities, to build the independence in communities. But it starts by investing in the people. And so somehow we've got to get more Black leaders in the community to be engaged in the response. Again, I'm really thinking about preparing for the next thing, the next virus, the next thing. And I know the messenger always matters. it always matters. The messenger always matters. So there certainly is a need to figure out ways to hire what I call risk communicators from the community. I mean, I'm talking people from the neighborhoods, the zip codes, where we know by the data that have had the greatest impact around COVID-19, for example. Because I've been asking the question, from whom and how is the need for testing being communicated? I'm still baffled by that. And who is the Black community listening to? And how do we know who they're listening to? Are some questions that still baffle me. Also, in terms of beyond the current pandemic, I almost see a need to build these networks around the country, the world, of that would be called like neighborhood risk communicators. And they are trusted leaders in the community that the people themselves will identify now as those trusted leaders. And these are people beyond the titles. I mean, you know, we tend to kind of go to the titles and all of that. And we are, in terms of an ongoing approach, we need to also, I think, just look at the data. And in the, like, for example, again, we should all be demanding that race is a required element for all COVID testing and data collection and reporting. And so COVID-19 certainly has demonstrated to me and to us that our communities cannot afford to be treated like everybody else. We just can't, we can no longer afford to accept that. And I also think that we should all be demanding that we generate, that there are plenty of academic institutions, including historically Black colleges and universities, that can help us to generate these national heat maps. And that way, so we can geographically identify the target locations of the spread of COVID-19 cases and the mortality by race, of course, with an emphasis on Black communities. And and after that point, we need to fight for data-driven funding decisions so that we really know where we need to go, how we need to go, when we need to go into these different communities. So risk communications, data, and then testing. And of course, we know that there have not been adequate resources
Dr. Smith,
identified.
one more minute.
Oh, wow. Cool. Great. Thank you.
I'm giving you a gift of 1 minute.
Okay. Thank you. Okay. To stop the spread. And so establishing mobile testing sites in the Black communities based on the heat maps, of course, and the need to demand that mobile test sites are in the best locations for the populations at higher risk. I mean, I hear about these test sites popping up, but did anyone ask the people at higher risk if they're in the right places? And how do we engage grassroots leaders, especially nonprofits, our nonprofits and faith-based organizations? And I can say that one faith-based model in the US is coming out of Charlotte, North Carolina, and it's called Village Heartbeat. And that model has been in place for managing chronic diseases. And these pastors have been toiling for many, many, many years to address chronic diseases. But what has been amazing, it's been a best practice. And so the World Council of Churches recently adopted this best practice model and developed a guidebook for the network. And so there are models out there. I guess I say all that to say that in terms of more health workers, absolutely, we need to shore up. I heard the doctor talk about that earlier. And so recruiting and hire contact tracers from the neighborhoods and the zip codes, building this long-term capacity in our communities too. It's not just the right now, is the long-term capacity, so we can become health advocates and mobilize our own health. So we need more community health workers who are hired so that they can help to provide non-medical care, support, services, and resources, help with dealing with issues of isolation, medication adherence, emotional support, et cetera, et cetera, et cetera. And there are plenty of models around for that. And then, of course, getting research. But the bottom line is nobody's coming to save us. Nobody's coming to save us. Dr. Hancock, nobody's coming to save us.
I know that.
There
And
you
I
go.
agree with you. And that's why I'm
So-
letting you make this very powerful statement.